do my head talk, check my nails. Baby, how you feeling? Head talk, check my nails. Baby, how you feeling?
All right, well, we first want to thank everybody, and we want to thank Nanick for inviting us. I think everybody's lives are crazy, and I think we did our first and only dry run about an hour and a half ago. But when Mary Kennedy comes knocking and says, "Can you do X?" A number of us will just say yes, and here we are. And so it's just really an example of what we're proud of what we've been able to accomplish as a health system. And hopefully we can share some of the things that we have done and that other people can take advantage of them. So again, this sort of got caught up with us. We didn't, I knew this was coming, but I think last week we were like, oh no, it's Tuesday, that we needed to get ourselves really, more aligned. And hopefully this will be a good presentation for folks. Meg, if you can go to the next slide, I'll get off my little stage here. So here's the three of us that are presenting. Yep, John is the manager of a lot of things at BMC. He's a very talented piece of our analyst group. He's the manager of our Ambulatory, our Willow pharmacy system, and he also leads our clinical decision support team. So and he's going to join Meg and myself on this presentation. If you can go to the next slide. So these are our two objectives for the night. So this was part of the handout that Mary had sent out. So we hope to identify some strategies that we use to increase access to vaccination and to also address the vaccination hesitancy in both our BMC patients and our employee population. And then we really wanted to describe how we streamline the workflow, because when we opened up some of these clinics, we had less than a week to do that. So next slide, please. So this is here we are at BMC. We were formed back in '96. We have over 500 beds. And I think probably the piece in the middle really kind of addresses why we're here today from a public health initiative, in that we do really serve a minority of residents out of the city of Boston. 65% of them identify themselves as racial or ethnic minorities. 50% have a annual household income less than the poverty level, and more than 30% speak a language that is primary other than English. So it is really who we were trying to target, because it was really this population that was adversely affected by COVID. And so from a system point of view, we are an Epic shop, inpatient, ambulatory, and rev cycle, and we are currently on version May 2020. We had hoped to go to 2021 this past spring, but other things came up. So we've pushed that off to the fall. So this is our Epic journey. We started well back in 2014. A couple of people on this phone, on this call, the two Lauras, McLean and Calcagney, were part of our Go Live initially. And we really did a number of installs. And one of our next big projects is next month is to replace our current GE RIS system with Epic Radiant. So, and a couple of major add-ons that we've done along the way, one of which I'm pretty proud of is that we actually implemented the case management system over a year ago. And we try to upgrade every 6 months, although Epic would like us to do it every 3 months, but then we'd get nothing else done. So next slide, Meg. So employee vaccinations, we started back in December. We had multiple waves that really based on how patient-facing you were. And we had multiple strategies to try to get employees vaccinated. And Meg, later on in this presentation, will discuss some of the strategies that we used. And right now, at this point in time, any employee at BMC is eligible to be vaccinated. I always tell my team I felt like the kid in the schoolyard that didn't get called on first because I was at the end of the first wave. So finally did get our vaccinations in the beginning of January. So this one tells us a little bit about our totals for vaccination of employees. So that highlighted column shows that we're at 81% of our employees that are in fact vaccinated. And then the one that's the lowest, the 65%, is really the contingent of the per diem staff. And I do think that a lot of those folks have been vaccinated in other places and just haven't really closed the loop. We did do wave 4 and 5, which included our EPIC and our ITS colleagues. So we're almost up to about 70% of those employees also. So totally, we've vaccinated over 8,000 people from our clinical and our employees staff. So you can see there's a couple of pictures there on the far right was Cheryl Tull, and she was really our first person that get a vaccine back in December. She is a proud woman of color who is the ACNO of Med-Surg, and she very much wanted to be the first person that got vaccinated. So when administration looked for folks to volunteer, her hand was raised first. Next slide, please. So these are just some vaccination trends by race. I'm not going to spend much time on this, but you can take a look at it in your leisure because I know these slides will be available, but you can see where we're tracking to. Next slide, Meg. So we started our patient vaccination back in February. We follow really the Massachusetts guidelines. We had multiple strategies to encourage patients to get vaccinated, and we'll talk a little bit about that. And then we leveraged EPIC and IT solutions to really assist. And John's going to spend a fair amount of time talking about how we leverage those two areas. Next slide. So this is a busy slide. This is my friend Eric gave this slide for a staff meeting, but it really does highlight a couple of things in that we did follow along with mass guidelines. Massachusetts really came to us and partnered with our CHCs to really help set up some off-site locations in the neighborhoods that we serve because they were some of the neighborhoods that were so highly impacted by COVID and really have so much hesitancy and really have a lack of the ability to get vaccinated. So we really did a lot of work in those areas. And you know, change was constant during this time. State requirements changed, the distribution of the med changed, our approach changed, leadership made some different decisions, our supply sources changed, it just changed today. And then our scheduling approach changed. Next slide, please. And so these are some of the off-site locations that we spun up. And I will tell you, most of these were spun up within a week. So we really did partner with our community health centers and our community organizations. So in Dorchester at Russell Auditorium, we partnered with Codman and Dot House and Upham's Corner and Harvard Street and Harbor Health. And then in Mattapan, we spun up a site in the Morning Star Baptist Church, and we partnered with Mattapan and the church itself. In Roslindale, we spun up a site and partnered with the Greater Roslindale Medical and Dental Center. And then we also partnered with them to start up a site in the YMC in High Park. And then, of course, we had our own sites at BMC, and there's a couple of those, and we'll show you that the next slide. So originally, we had 4 sites on campus. For those folks that have some sort of familiarity with BMC, over in the Dowling building, which is really part of our old inpatient facilities, we started up our Dowling ground, which is really where we started vaccinating employees and now have transitioned to patients. Initially, we started with 5,000 vaccinations, or 500 vaccinations a day, and then increased to 1,000. And then 85 East Concord Street, we have a capacity now of up to 1,000. Shapiro, which is one of our newer ambulatory clinic or ambulatory buildings. We have a capacity of over 400. And then Crosstown, we really just targeted patients that were coming to that area for clinic visits. So if you came for a clinic visit, you were asked whether or not you wanted to participate in and get a vaccination. And then we opened up our partners or our off-sites with our CHC partners, and they were open vaccination sites, so people could schedule themselves. So we had Roslindale, we had Morningstar, Mattapan, we had High Park, and then we had Russell in Dorchester. And you can see 1 week we opened the first two, and the next week we opened the other two. And you can see the capacity that we expect to be able to vaccinate in those areas. And now we have 2 more sites, one of which will open today. And that was in a function hall in Roslindale, which we expect to move the current existing clinic to that space. So it opened today, and we hope to give up to 1,000 shots a day. And then we have a Baptist church in Roxbury that we're opening up on the 19th, and we hope to be able to vaccinate over 400 shots, provide over 400 shots a day. And we have a number of them, new sites on the horizon. Next slide, please. So this is just a map of our area and really how we targeted our patient population. And this was part of the MassDove site. And this was our results in March. So we were pretty proud of this in March. So you can see the first dose, we had over 220,000 people that were vaccinated, and the second dose over 6,000. But the next slide will show you now in April, this is what we're up to. So first dose vaccinations, we're almost at 58,000. And second dose vaccinations, we're almost at 18,000. And then the next couple of bullets are the amount of appointments that we have through the 14th. So we have a total of over 11,000 appointments scheduled. And by our neighborhood, 62% of our people that we have either vaccinated or have scheduled for vaccination come from the Boston area, and 38% come from outside the area. And we have about 300 walk-ins to these clinics and these sites on a daily basis. And then you can see the other piece of this from the public health perspective, and this was just in 1 week in late March, 31% of the patients that we vaccinated were Black, 14 were Latino, and then 27% were from a really highly socially vulnerable patient population. And then this is one of the pieces that I know John will talk about, but we're proud of this in that we developed a BPA, or a best practice advisory, that would alert the providers and the staff in the clinics that this patient was eligible for vaccination. And we've, by that method, have vaccinated over 15,000 people. Next slide. So here's a pie graph. I'm not going to be the first person to actually explain this. I'm the only, but you can take a look at it. So it really kind of divides how we've done based off of race and based off of social vulnerability index. Next slide, Meg. So we've also been pretty fortunate in that we've been recognized as a key partner with the state and through the community as a trusted partner. And so we've been part of multiple media press conferences. Governor Baker came to the Morningstar Baptist Church a few weeks ago. Kate Walsh, our president, was part of that press conference. And then also Maura Healey, our Attorney General, went to the Russell Auditorium. And then some of our experts within our walls of BMC, in particular, Dr. Thea James, have really been front and center. And Thea was actually on Nightline on ABC. Next slide. That was not 9. Okay. And so I'm going to turn this now over to Meg, and she's going to talk a little bit about addressing the vaccine hesitancy in both our patients and our employees.
Thank you. So We have used a lot of media to address this. And of course, I can't get this to go forward now that I'm doing it. I don't know what I did to this. Okay. So the first thing we did is we really wanted to reach out to our employees. And we did that in a number of ways. One thing that we did is we had virtual drop-in vaccine Q&A sessions so that if they were home and had the time, or even from the floor, they could call in and speak to the experts and ask questions in a safe environment. And then we set up booths in the Menino lobby. This was really great because we used a really diverse team of leaders who were known to a lot of the staff, who would come and sit in the lobby in a booth and just answer any questions they might have. So one day it might be a pediatrician, the next day it could be someone from pharmacy, somebody, maybe one of our nursing directors. And it really allowed people to talk to people they already trusted and had relationships with, and could ask questions and trust their feedback. So we found that was a really positive thing, and it got a lot of traction. We did have our internal hub, and it was focused on employee education. I will say this was a wealth of knowledge if you went there. So we had a lot of fact sheets, we had a lot of answers and questions, and all our videos that we did in other forums were here. But the staff member would have to be really proactive and have the time to go to the site. So it was good news that they didn't just rely on this. But it did become a place that if a manager or a leader got a question they didn't know the answer to, they could go there and find information to share with their staff. We made a lot of news with our dancers, and we had on December 14th, they celebrated that we received our first shipment. We're the first mass hospital to receive Pfizer vaccine, and we were ready to start vaccinating. And then they got, the two of our gentlemen were so famous from this, they actually were then reintroduced on TikTok and other forums. Engaging employees helps engage patients. So we really did a lot of work to engage employees, to really reach out to those who had questions. But then what we wanted to do is make sure that leaders worked with their teams to ensure eligible patients were flagged with BPAs or had their questions answered. They really realized that if the staff had their questions answered, they could share the information and disseminate down to our patients. There were a lot of meetings where people would share information like this that you have here in front of you, showing how our ambulatory clinics were doing, and information to help people increase their knowledge. During the pandemic, we used a lot of videos, not just for vaccination information, but with anything. During the height of the pandemic, our CNO, Nancy Gaden, did a daily video. And we found that this short video really helped disseminate information much better than email, much better than other methods that we had tried. It was short, and it brought out information that the staff needed to know that was vital for that day. And it also let them know that Nancy was there and she was accessible and she was trying to communicate the best she could. So we used that same information to try to get information out to the staff and patients. So Nancy did a video. It's a 3-minute video. It was first internally available, and then it was made externally available. And we had it translated into Spanish, Haitian Creole, Portuguese, and Cape Verdean. So I thought I might share this to give you an idea. Let me just switch to it.
Hi, I'm Nancy Gaden, the Chief Nursing Officer. I'm here to talk to you for a few minutes today with my smartboard about how the COVID-19 vaccine works. Because we work in a hospital, and I think we might be asked by our friends and our neighbors and our patients. So it starts with talking a little bit about the immune system. The immune system is really, really important in fighting off against germs that come to our bodies. And one of the big pieces of the immune system is in our blood. Our blood has 2 main types of cells in it. red blood cells that take oxygen to our tissues, and white blood cells that are the star of the show today. Oops, I'm going to make them blue. That are the star of the show today because the white blood cells make antibodies. And antibodies are what fight against illness. The COVID-19 vaccines, Moderna and Pfizer, both work the exact same way. Inside the vaccine is just a set of directions. It is called messenger RNA. The directions come into your body and tell your body to make little proteins that look like the outside of a COVID virus. The vaccine does not have any COVID in it. It only has a set of directions. And once your body makes these little proteins, your body then responds, your white cells send antibodies, and your body responds by making antibodies to those proteins. In a few hours, the directions actually go away, just like Snapchat. But your body keeps making antibodies for the next couple of weeks. At the end of a couple weeks, even your antibodies go away. But that is where the magic starts. Because we have white cells that are memory cells. And the memory cells remember exactly what the little outside of the COVID virus looks like. And so when the memory cells are going around your body, they're always looking for viruses and bacteria that they've seen before. So if you come in contact with another COVID-19 virus after you're vaccinated, your memory cells remember it, and they quickly run and begin to make antibodies to fight against it. I know you love my drawings, but there's the real picture of the antibodies and the COVID virus. And that is how the vaccine works. It's a set of directions that makes your body make proteins, and then your body makes antibodies to those proteins. Then your memory cells remember what the outside of that COVID virus looks like. Bye, bye, COVID-19. Please consider getting vaccinated. Thank you.
And again, this comes in different languages, so you can share it with a lot of our patients that English is not their first language. And staff has found that very helpful. Let's get back to this. We also, as Geralyn mentioned, a lot of people got vaccinated, and then we actually videotaped their information on why they got vaccinated and what it felt like for them. And this is Cheryl Tell, who Geralyn referenced before. We actually took these and posted them on our homepage, but then on Facebook and Instagram. And I can't tell you how many people will say to me, oh, I saw someone from your work that talked about this, and I didn't know that. And that was really great information. They tried very hard to make sure that the people they videotaped reflected not only our employees, but our patients. And so it's a very diverse group of people. I just want to share with you a quick clip from one of them so you can get an idea of what they're like.
Hi, BMC friends and family. My name is Sebastian Hamilton. I'm the Associate Chief Pharmacy Officer for the Outpatient Pharmacy here at Boston Medical Center. So let's talk about hesitancy and specific people of color. Hesitancy is real, and we need to acknowledge that. And unfortunately, African Americans, Latino, and other people of color have been impacted by this virus the most. When I talk to my family about it, I never dismiss it because before I'm a pharmacist, I'm a man of color. And so I know where it's coming from. 1972 is when that Tuskegee experiment ended, which, is not that long ago. I also want to ground ourselves to make sure that we then look to the future in a more of a positive yet measured way, so that now we could change the story, change the narrative around being disenfranchised by healthcare to now being empowered by healthcare, by embracing healthcare, by embracing facts and truth and trust. So we want to make sure that we get the right information today in this day and age of information overload, so we can make the right choices to get vaccinated. I myself have been vaccinated. I didn't hesitate when it came up, because the way to change the narrative and take some control and become empowered is by getting vaccinated, in my opinion. It really well arms you against the infection. Our community's been impacted the most. And you also protect those around you, which I think is exceptionally important. So don't think about only just yourself, think about your community. I'm looking forward to my second dose, and I will continue to wear my mask, social distance, wash my hands, and all the things that we can continue to do to make sure that we are all safe in this horrible pandemic, that this is the only way we're going to get through. I think if we want a summer, we want holiday season again, we want to go back to school, back to normal life, this is how we do it. And I can't think of a more straightforward way to get there by becoming vaccinated.
So as you can see, they're very short clips. They hold the attention. And we continue to send the message in lots of different forms. In fact, after writing this the other day from work, I was walking out, and I probably walked by it a million times, but noticed a big sign that was in the lobby, right where all the patients and employees exit, that talked about getting vaccinated. We also have on our site things from people in the community that people respect. So this is another video. I'm not going to show it to you, but I did put a link if people wanted to look at it later. And it talks about if it was available today, would you take the vaccine? And Reverend Liz Walker is in there. And it talks about how safe it is and why people of color should get it. And it talks about, in a live poll, nearly 40% of the viewers expressed resistance. And so it really addresses that resistance and has people from the community that other people probably look up to and trust. And I think that's the key to our messages. We do a lot of celebrating at BMC. Every time they open a new place, there's pictures taken, they post them places, they show them at lots of forums. We have a lot of town halls to share it. It's on the social media. So there is a lot to celebrate and a lot of thankfulness for the people that are doing the work to get these places opened. We're engaging patients in the community through other multiple channels to support vaccine adoption and access to appointments. Our goal is obviously to provide accurate information from trusted sources and support vaccine adoption, ensure access to appointments, especially for people of color and other high SVI individuals. Vaccine site engagement, we do outreach to patients like letters, texts, emails, phone calls, Q&A clinician booths that are not only on campus, but in some of the places that we've opened up. Staff support that I think I've talked a lot about already. Again, multi-language handouts, direct to public engagement. The Ask a Doc Zoom sessions have now expanded from internally to externally. Collect interest lists and outbound calls to schedule multi-language educational materials like the video I showed you and other media. Staff email accounts to ask vaccine questions. Community dialogues with local leaders like I showed you with Liz Walker. Materials for community leaders so they can also do this information sharing, and multimedia campaign. I know that we just had people at Stop and Shop this weekend signing people up in certain areas of Boston. We are really proud of how we've also reached out to the geriatrics from our institution in an effort to bring vaccine directly to the elderly patient. BMC Geriatrics Home Care Program is making nearly 40 visits a week to homebound patients in Boston neighborhoods to administer their first dose and answer questions they may have and their families. The next effort is to continue the multilingual geo-targeted digital campaign and further engage key audiences. We are going to continue to address hesitancy and provide educational resources, showcase resiliency of the community and our path forward together, build momentum and encourage vaccine uptake, have our campaign landing page, our social media, our testimonials and educational videos. It's on radio and print and media ads on niche community stations and outlets, and community toolkits with educational materials. We plan to build off ongoing community leader forums to reach specific community members through Zoom town halls. And you can see here the list of tentative ones we have in different languages for all of April and June to hopefully target people who may have not gotten the information in other ways. And we'll continue to improve access to information and register through direct field work. Like I said, like in the Stop and Shop, bilingual canvassers from target communities will utilize every action and minivan technology to go door to door. They will answer questions about the vaccine and sign people up for appointments, wait lists, socially distanced, and or point individuals to town hall and additional educational materials. They'll also distribute door hangers, bodega signs with local businesses and community members, and champion group like faith leaders, fraternities, sororities, elected officials will engage community for weekends of action and other events. These are some examples that I just pulled off social media quickly. On the left, you have Dr. Hollis Day, our chief of geriatrics, talking about why it's safe for geriatric patients to get COVID vaccines. And on the right is an advertisement for a Zoom with a doc. And then just recently, we had 5,000 vaccines at our High Park location, and they celebrated that too on Instagram. So I'm going to hand it over to John, who's going to talk about streamlined workflow to schedule and administer the COVID vaccine to patients with a rapid deployment time.
Yep, so thank you. Yes, I'll be focusing on the scheduling and administration workflows within the EHR. And like Geralyn said, we do a lot of these now within usually a week. Within 5 days, we can stand up a new clinic. So our original concept at BMC was really to have an open network of vaccination sites. So we have those on site at BMC, which we have 4 of, and then also our partnership with our CHCs. And that gives us the ability to strengthen our collective ability with the state for vaccine supply and access, enhances our ability to coordinate across our neighborhoods and really promote as much uptake as possible, and support a stronger analytics and forecasting for supply chains. As everybody knows, supply has been variable as when it flows in, and really being able to target our different locations for that. And then lastly, to really reduce redundancy, to use our resources to the best of our ability as we stand up all of these various clinics. Next slide. So first of all, we want to engage the community and really gauge interest for the vaccine. So we published independently on our website, it wasn't Epic or anything like that, a web form to gather as much information from individuals who aren't eligible and to put them in a queue for when they are. This is regularly monitored, reviewed, and as soon as somebody is eligible, the call center will reach out to that patient or individual and schedule their appointment for them. In the coming weeks, we're actually going to be transitioning to a more streamlined Epic interest form, which will allow us to actually use all the same contact information without having to have it externally to Epic. So next slide. So there was a variety of scheduling approaches that we took. I am not the best scheduling expert, but I will say that we used our call center, has been and is integral to our outreach to our patients. The CHCs, the community health centers, also have an option of direct booking. We used also connected to the open scheduling site through the state Patients can go to the state website, find our location, and schedule from there. And then we used a variety of other options. So private open scheduling. So we created some sites specific for CHCs and healthcare for the homeless that they can go to on the BMC network and schedule patients in there. And we also really tried to use our patient portal for self-scheduling as well. Go to the next slide. But there's several impacts on it, significant ones. And especially when you are using the patient portal, which is MyChart. I know everybody is an Epic. And really, we didn't want to impact day-to-day operations. So we needed to make sure that our telehealth services still operated while we also offered the ability for patients to be able to jump in and self-schedule on different various websites. So we increased server capacity around that. We actually dedicated some servers. Oh, Meg, did you jump?
Ooh.
Good, because I didn't memorize these slides. So we created some dedicated servers to MyChart. We made sure that, like, for failover, we had failover ability if we had increased traffic due to bandwidth. We were sending out, or are sending out, a lot of communication, a lot of emails, a lot of texts, a lot of MyChart messages. So our technical team has been very focused on making sure that our systems don't lag, that we maintain the integrity, both for workflows around vaccination and, again, our day-to-day workflows. We installed a lot of out-of-cycle SUs, had a couple unscheduled downtimes just to be able to get some of the functionality that we need in there. And for several of these newer Epic functionality, they would tell us, you should probably take 2 to 3 weeks or a month, and we would get them in and built within a couple of weeks. And our cadence team really, really rose to the occasion for that. So next slide. So it all started with reporting. Our population health team is really the group that identified our eligible patients. They generated their data from the data warehouse, and they randomized it and loaded it into our Epic registry. And from there, we use that Epic registry to flag the patients who are eligible at any given phase with a health maintenance topic. We started loading that data weekly and quickly learned that we needed to do it nightly. So I think it took a week before we started doing it every night. The reports below, I'm not going to go through all of those, but those are the operational reports. So our reporting team did an excellent job giving the data, the operations, clinical operations, and the clinic operations teams to know how to disperse vaccines, where to open appointments, where to close down, what was quickly filling up. All of those reports there kind of contribute to the day-to-day operations of all of our vaccination sites. Next slide. So I'm going to go through our 4 primary workflows that we have. It started out with the employee vaccination site. We moved on to on-campus mass vaccination sites, then off-site, and then Jerry. So the first one we'll visit is employee. Next slide. There's probably a lag, isn't there? So our employee vaccinations do use the mass vaccination workflow. So I'll show that in the next slide. But the important information around it was the first clinic that we actually stood up at BMC. All employees were scheduled through our call center, so there was no self-scheduling or MyChart access to schedule. Notification and tracking was done entirely external of the EHR, and hospital operations really just wanted to keep that outside of Epic. We stood up a unique location for employees that now, due to the volume being lower, does employees for the first 2 hours of clinic, and then the rest of the day we vaccinate patients. And then all scheduling and documentation is completed within the EHR. So the on-campus vaccination sites, we have 4 of those. We use the workflow as a standard check-in and check-out with what we call mass vaccination administration, or for those who are familiar, one-step immunization. So the nurse, or I can't say nurse anymore, it's vaccinator. The vaccinator will locate the patient on a patient schedule, select them and scan a barcode. And when they do that and answer all of this, barcode populates everything on the left in that screenshot below. They answer all the questions on the right. And as soon as they click accept, that creates the order and documents it all at the same time for the vaccinator. So there's no work ahead of time or anything like that, other than scheduling. So it leverages barcoding. One scan populates almost all of the required fields. The equipment we use on campus is workstation on wheels with scanners, and the check-in and check-out use standard workstations. Patients who are eligible on campus must go to one of these centralized locations, but we did give providers some tools to be able to identify them, and that will be on the next slide. So our in-clinic workflows. We wanted to gauge interest as much as possible for our patients, so we blanketed all of our workflows, that being front desk, MAs, RNs, MDs, with being able to document interest via the storyboard in Epic. It's a flow sheet row that they were able to click on and simply document if they were not interested or interested, and I'll have a screenshot next that will explore that. But so we'll get there. But we displayed that interest and the COVID vaccination status on the patient storyboard, so everybody could see really the continuity of if they were eligible or not, and if they were, to really kind of advocate to be able to have a discussion with them or the provider or nurses if there was hesitancy. We created that best practice advisory to, for our providers to direct eligible patients to on-campus vaccination sites. So one of those fours, and 4 clinics. So that was for in-person and telehealth. So it was really meant to educate the provider and flag them and let them know that the patient's eligible and encourage them to go and get vaccinated. So again, we took every opportunity we could to gauge interest and really trigger the provider to have a meaningful discussion about any hesitancy with the patient, whether it be an RN, an MA, MD, is to really direct them, somebody to have that conversation, and even during handoffs. So the next slide actually displays the BPA that Geralyn, or maybe it was Meg, who mentioned that fired approximately 15,000 times. So this would fire for any eligible patient, and that was simply if they were had the health maintenance topic that was on them. And it gave them an opportunity to do a couple of things, actually. For one, it gave them the opportunity to document interest. And we also knew that interest could change, and we were hoping it would. So it isn't like one time you document interest, but maybe you have a discussion, and maybe they were absolutely, no, I'm not going to take it. But maybe after a couple discussions, they were going to defer it and think about it, and then maybe they accepted that visit. We also gave them the opportunity to document the health maintenance should they, as you know, the clinical guidelines have changed from week to week. So maybe the physician doesn't think that they're clinically eligible for the vaccine. So they can go into health maintenance and actually defer it for that period of time. And then lastly, if the patient already got the vaccine somewhere else, they can jump into the immunization activity and document it as a historical vaccine or query MIIS and get that into the chart so we know where they are and if they're vaccinated. Next slide. So for our off-site locations, we currently have 4. We're going to be expanding to 5. That workflow uses a standard check-in with a laptop, check-in and check-out. And it uses Rover. So Rover is a mobile application that is on the iPhone. And so all of the vaccinators simply use an iPhone. There's no workstations or anything like that. There's several screenshots I could have given you, but there's one on the right that displays what the vaccinator is using on Rover. So they use iPhones for the vaccinators. And what's great about this is when they check in at those mobile locations, it actually generates a 2D barcode and sends it to the patient's email. And the vaccinator can scan that 2D barcode and it brings them right up on the phone instead of having to search any patient lists or anything. So the attempt is to have as much, input as possible to have an efficient throughput. So again, it's iPhones and then laptops for check-in and check-out. So this leverages barcode scanning, and I'm going to talk about MIIS, or the Massachusetts Immunization Information System. Some of you might be familiar. Hopefully, you're lucky enough not to be familiar. It's a challenging system, but so our pharmacy has created all of the barcodes for our vaccines, and they all get labeled. Either they get sent with the stock if we're deploying it day of, or for on-site, our pharmacy actually draws it up and labels it for our vaccinators. This is essential to some of the work that we've done because we have partnered with our CHCs to actually deliver their federal stock. So for Codman and Boston Healthcare for the Homeless, they have actually given us their federal stock, and we document it, but we have to use very specific lot numbers to make sure that it doesn't decrement against what we would consider state supplied. So lots of stock flowing around, and operations monitors it, frankly, every couple of hours. So next slide. So MIIS is Massachusetts Immunization Information System. Every vaccine that we ever give, we are required to report it within 72 hours of any vaccine administration. And we originally just started with state supplied and sending what is considered BMC's PIN, the identification number for the institution. Then we partnered with our CHCs to administer their federal stock. So we entered legal agreements. We had legal and the state involved and finance. And so we initially were trying to use just location and the lot numbers to distinguish that stock and distribute it. Oh, thought that was my extent, Meg.
Sorry.
It's okay. So with that being said, we quickly learned to become more agile. We needed to move to just lot. Like, we couldn't consider location anymore because operations wanted to move all of the stock wherever possible. Like, if we had more appointments in Mattapan that day, to move Boston Healthcare for the Homeless stock over there. And it was just too hard for them to really say, on this day, we're going to use state, on this day, we're going to use federal. So what we did was we pharmacy creates labels specifically for the stock that they have. For instance, Boston Healthcare for the Homeless has a lot number with FB in front of it, and Codman will have an FC, and that way when we scan it, that lot actually pulls in automatically for the vaccinator. The vaccinator doesn't need to worry about selecting a lot; it will pull in. And that way, the interface, when it sees that FB or FC, it sends it to the state with the appropriate CHC's PIN. And then it also tells the state that it's federally supplied, so it doesn't decrement or cause any supply issues. Because if you don't have the proper in and out, the state will not give you more stock until you've used up the ones that you have. So again, pharmacy creates those labels, and they're essential to our workflow to be able to have this efficiently done. So next slide. So our Jerry Van workflow, we're very proud of this. This has been a great workflow. It really follows the mass vaccination one, that first one I walked through with patients and employees. But the couple of caveats to it is because of billing and charging workflows, we had to create a new department. We needed to make sure that the admin fees and everything routed to a specific cost center. Also, this gets into things that I don't know, but it's an MD-driven workflow, and they had to lease time for MDs so they could give them out in the field. So the patients are scheduled ahead of time. They basically have 2 visits for their traditional home visit. They have a vaccine administration visit, and then they have their traditional home visit. And so that way we always have 2 account numbers and charge for the day. So, next slide. So I'll just quickly go over this. So we had training and then after visit summary updates. For training, we learned that it had to be just in time. So we created PowerPoints and tip sheets by our training team. We had a designated clinical lead every day at each of the sites that will do that training. And we learned vaccinators change day to day. They may only do one shift. They may only do 4 hours. And so it's a challenging thing where we need to make sure that we're consistently training every day. For the AVS, and we actually paused printing the AVS, traditional AVS in these locations. We use pre-printed materials, but for like ED and when we expand, we've added an eligibility section. So any patient that was eligible, they would have a little blurb of how to go and get the vaccine, who to call, where to register for, or to talk to their provider. We have vaccine information sections if they receive the vaccine. We actually have a really very cool illustration for corona safety section. So it's in not cartoons, but illustrations to be able to signify how to still stay safe from the corona vaccine, and then post-administration for each vaccine. So the AVS would look to what vaccine was given and be able to say a summary of what they received, post-care, Tylenol, Benadryl, those kind of things, post-administration. And that was all rule-based. So challenges we faced, which everybody I'm sure has, is those immediate timelines required. Like we said, we stand a lot of these up within 5 days or within a week, but it was a lot of yes, no changes, even from location. We're going to be here, and then nope, that fell through. So we really learned where we had to really ask the questions to make sure we had what we needed. Logistics, for instance, YMCA location actually breaks down every day and sets up every afternoon. So they would have to find a location to be able to securely store like all of the equipment, make sure at the same time it was all get charged overnight and that kind of work. In addition, equipment and connectivity, things like, do they have hardwired or do they have Wi-Fi? If they do, can we use it? Maybe the organization doesn't want it. One location actually had a school in their facility, and they didn't want us, slowing down their internet connections for their students. So we had MiFi versus Wi-Fi. All of the new equipment, we would run up against shortages. Again, those Epic server impacts. So we don't want to stall day-to-day operations, but we need to make sure that we can support MyChart and scheduling, that state eligibility and the guidelines that were constantly and are constantly changing. We all lost Johnson & Johnson today. So the scarcity of the vaccine supply and sourcing also impacted and was a challenge. And, stretching the EHR, what was capable, what could we do? For instance, mobile documentation and Rover, scheduling options, really blanketing as many workflows so, our operations could get as many scheduled patients as possible. What could we do with MyChart? But what can we do and, again, not stop day-to-day operations because we still have to see patients. And then the vaccinators' access and training. I think that was a big one. We can't say nurses just give vaccinations anymore. We had pharm techs, MAs, med students, physicians, people that we would learn in 20 minutes before that they tried to vaccinate somebody and they couldn't. And so security was a big thing of just really trying to make sure that everybody had the access and really identifying as many roles that we're going to be doing that. Our patient challenges. Not all of our patients are technically proficient, and there's just in general access and trust issues. And we at BMC have an actual lower patient portal adoption. And so that is a challenge that we recognize. That's why we don't just rely on MyChart. We're using text messages to communicate, emails, letters, a variety of reaching out to the patient. And then the rapidly changing guidelines, clinical guidelines, for instance, needing to have a 14-day interval between vaccines, monoclonal antibodies, you can't receive the vaccine if you've had that within 90 days, and accommodating that in the various workflows that we have or are trying to stand up. And there's a summary count of the hardware, and I think that's out of date already as of today. But you know, you can see there was quite a lot of hardware that was distributed through all of these various locations. And so next slide. So it takes a village. This is all of the teams we engage each time we stand up a new pop-up clinic. We definitely need a project manager, just because like for myself, I focus on the clinical standing up of it, creating the departments, making sure the scanners are there and the workflows. We need somebody who literally just pays attention to networking and phones and all of that and can order it without me stressing out. So we have a really excellent team who has really gotten this down to a science. And then next slide. So what's next? So we are doing, we'll be doing additional on-site and off-site clinics. We were actually supposed to start ED vaccination today with Johnson & Johnson because we wanted to have one dose, and then we all know that it got paused. So we had some sad ED providers. We're also attempting to work on an inpatient workflow, especially for those interested at discharge, but that goes and points to that constantly changing clinical guidelines too. We don't want to, you know, there's a lot of things to work around. Like if it gives the patient a fever, that could extend their stay, things along those lines. And we're finding that discharging patients to locked units is our biggest ask. A lot of the locked units around the city are actually asking for the patient to be vaccinated because they don't have ability to sequester them to a unique area. We anticipate, you know, opening more vaccination with the next phases. So we try to discuss that as soon as we heard April 19th for all populations. We tried to discuss that right away, so we knew what our plan of action was. And so we're already ready for April 19th in the expansion, and we've actually started for some of our 16-year-olds and up for our PD patients internally for our patients. Obviously, younger populations will be eligible next week. We're also just exploring online scheduling to reduce checkout staffing needs and also the call center. They have been integral to really getting patients in, but they have also been inundated, and they probably need a break, to be honest. Self-scheduling for the second doses, we do all that scheduling right now at checkout, so we're hoping to be able to do that within MyChart soon. What can we do in general without MyChart? We're pushing Epic to really enable us to not have every patient enrolled in MyChart to use that functionality. In general, we're also doing MyChart Spanish. Monday, we started e-check-in, and we are transitioning to the web interest form that Epic has generated so we can gather that information and then actually send a scheduling ticket right out to the patient. I think that was my last slide. Yes, it was.
So I'll just end and say again, thank you for inviting us to this session today. So, you know, our goal is to support our communities, especially those that are hardest hit by the virus. We really want to set up a community vaccination network. We do know that vaccines don't save lives, vaccinations do. So we really need to work on overcoming vaccine hesitancy. And we feel at BMC that everybody has a role. So that's really why we spent a fair amount of time working with our employees, because they were folks that people asked, whether they were family members or neighbors, colleagues or whatever. So we did really find spending time with our employees and really educating them on the value of being vaccinated was really a time well spent. And then we do really hope that we can participate in a vaccine that will be most impactful so that we can promote a healthier equality next year. So Meg, is that it for our slides? I think we have one more video, right?
Yep, I think we also just have at the end of this contact of the people in our group and
This is
John.
us. Yep.
And then we're gonna show this.
Walk your fine ass out the door. I do my hair talk, check my nails. Baby, how you feeling? Hair talk, check my nails. Baby, how you feeling? Feeling good as hell. Baby, how you feeling? Woo, girl, need to kick off your shoes.
I will tell you that the two gentlemen that star in that actually hold like little dance things down in the housekeeping room when people need to let off steam periodically. They've become quite famous on campus.
Wow, you guys have done an amazing job. I am blown away, and everyone seems to be so engaged. Your employees, the patients, the dancers. It's just incredible. I'm sure there have got to be some questions for these folks. There's so many comments in the chat saying what a great job, great teamwork, which I would agree. I'm actually getting a little tearing up a little bit about thinking about how many people you've impacted, how many vaccinations you've delivered. So you really have made a difference in this pandemic. It's just incredible the work that's gone into it.
Thank you.
Yeah, it's been really a great thing. So we did get one question, John, that I'm going to ask you. Did we use lot managers to support the vaccinators?
We did, yes. So we use Lot Manager, and pharmacy maintains that for all of the organization. So we have a couple of pharmacists who really focus on the distribution, and some of the stock, just so everybody knows, is actually stored, say, at Codman Community Health Center. And so the community health centers actually communicate with the pharmacy director and tell them what lots they have, and they generate barcodes for them ahead of time and courier them out there daily.
I think that was great that you were able to use Rover in your vaccination site. So did you have to train any user that came in that hadn't utilized that type of technology and get them all set up with access? I kind of know how difficult that can be.
Yeah, the access, we tried to really coordinate with operations to make sure that, they could send us the list, but they were so over inundated. We really did try to blanket as many of our security templates with access in the beginning. So MAs and farm techs and pharmacists, so that way when we just provision them, they'd automatically have access. But each day, probably each 4 hours, to be honest, they do training around Rover and have really simplified it. Rover is pretty intuitive, so it's not too bad, but there are some discrete steps they need to make sure that they're in the right place at the right time.
Yeah, I would almost think it would be easier to train and utilize Rover than it would be a full laptop version of Epic.
And truly, we implemented Rover during the pandemic. It was one of those projects that we always wanted to do, but Meg and a couple others really, with Kathy's help, I think we spun that up in a couple of weeks.
Wow.
And really did a rollout to our hardest hit inpatient areas with Rover, and then rolled it out to the rest of the institution. And then to have it actually go into the ambulatory space was really kind of neat.
And the staff really trained each other because they wanted to use it so badly. I feel like pre-pandemic, you would have had to have a class for them to go to. And they really adapted, and we had some real great super users that went out there.
Yep, talk about building the plane as you're flying.
Yes, yes.
Yes.
There was one question, if you had a designated provider for the vaccine orders, and John responded, yes, they have one provider that can be defaulted. And then there was another couple of questions. At the offsite location, did all patients have their own iPhone or Android device? Was there any issues with not having the technology?
Patients don't have the devices, but the vaccinators do. And each vaccinator gets one, and in some workflows, they actually have a vaccinator and a documenter. Surprisingly, there haven't been, knock on wood, because we're going to open more, many issues with technology. So our infrastructure teams do a walkthrough of each location, assess it if it has Wi-Fi, and if it doesn't, if we need the Verizon MiFi's, and we support both methodologies. So we can make sure that we have connectivity, and we have, again, knock on wood, only had one connectivity, like 1 hour once through all of this.
And I think that because they were setting up sites so quickly during the pandemic for patient care, they really got good at having a clear checklist of things they needed to do. And so they're pretty thorough. I think because we had that experience, they are ready to go check, and they don't want to be called back because they forgot to do something. So they do a really thorough job when they're setting up.
They have it down pat by now,
It's
right?
also, yeah, it's just another example of how you can adapt to in a pandemic. You know, it used to take us 2 months to set up a new location. Now we can do it within a week.
And another question, do you have a plan on how to schedule the second vaccine for inpatients now that J&J is on hold?
So we are still working on our inpatient solution, and we haven't nailed that yet. Truly, original marching orders was to make sure that a patient that was discharged had an appointment that they could get a vaccine post-discharge. But now that we're getting a fair amount of pushback from some of our referral places, SNFs, locked facilities, and the rest, we're really kind of re-looking at that strategy. But there are a lot of issues with the inpatient world, and I don't know. We try it, and we were going to go with the J&J because it was a one-shot deal. Now that that's on hold, do we put the inpatient back on hold? I don't know. But today was supposed to be our day to start with the ED, just because we know a lot of those patients are episodic, and we were trying to vaccinate as many people as we could. But that also went on hold today. So I don't know where we'll go with inpatient, truly. It is still a challenge. What do you do with the vaccines in the clinics? You want to use them before they expire, but at the same time, you don't want to hold up discharges, throughput. There's a lot of challenges on whether or not you want to vaccine the inpatients. And then the inpatients are in usually because they're sick. And do you want to vaccinate somebody that's sick? So, there's just a lot of, thought going back and forth on whether or not this is a good thing, or do we need to step back?
One other thing on that is, with the flu, it's so standard and been around for so long that it's easy to say, these are the patients that should get it, and the doctors don't really intervene. But I think if you set something up, really, you have to make sure that the doctors are involved with each patient and evaluating each patient. And how do you put that in a system that's not so overwhelming they can't care for their patients? And then with the ED, if the patient's leaving, but then they get admitted and we've vaccinated them, is that going to cause problems? I feel like when you go on those calls, if you miss one, it's changed so rapidly. Whereas, in the past, you could miss a meeting on a committee and you'd come in and kind of be still talking about what they were talking about the last time. Now you miss one and you feel like you've missed like 4 episodes of a show and you're so far behind because it's moving so quickly and changing every day.
Yeah. Very dynamic environment, huh?
Yes.
So there's also been a couple of questions in the chat about using some of these presentations or these videos. Nancy Gaden is very much for sharing her video, and if that will help either your students or your neighbors or your friends and family to really overcome a hesitancy of getting vaccinated, please use that. You can get that video off of our BMC website, our external webpage.
I put links in the talk too. And if you look at the Facebook, if anyone's on Facebook or Instagram, BMC shares a lot of those videos there. So they are really accessible. I showed you Sebastian, but there's like 20 other people that are talking about their viewpoints on vaccination or their experiences. So you really can find one that's suitable for whatever situation you're looking for.
Great, thank you for sharing. And there's, I think, one last question. How are the remote sites managing the storage and the temperature and the vans as well as the remote sites?
So that's a good question. I don't entirely have the best answer for you. I know that our pharmacy manages all of our storage and distribution. The off-sites, the 4 off-sites, other than Codman. Codman stores their vaccine at the Codman CHC. The other 3 off-sites get couriered vaccine daily, and it actually gets returned daily as well. They do have refrigerators and freezers there to be able to store it. The vans, I believe it's some magical cooler, but it's something along those lines where they take out a very minute, like 1 vial, maybe 2, because they're only vaccinating about 40 a week. So that's usually about 1 vial to maybe 2. So.
One thing about storage, that is one of the biggest other things we talked about with the inpatient as a barrier. You think of like your ordering process and sending meds up and having it in the Pyxis. You can't really do that with this. And so having the timing of ordering and administration and delivery of med will be a real obstacle in inpatient too.
Yep, we're making progress, but learning something new every day, aren't we?
Yes.
Almost like you
Great.
need a backpack. The vaccinator goes with their backpack. That's a cooler.
Like Ghostbusters, but vaccine busters, the jetpack on the back. Good idea, Juliana. All right, well, I'd like to thank you 3 again so much. Just a phenomenal, great presentation. And Neenah is very lucky to have you guys as part of our organization. And Denise says you're all doing incredible work and should be very proud. The impact you are all having for vulnerable populations is amazing and so important, and I couldn't agree more.
And we'll be sending out the evaluations so you can get CEUs for this wonderful program. And Neenah continues to offer these great evening programs with the help of our informatics community.
Well, have a lovely rest of your evening, everyone, and we hope to see you again here May 24th.
I do my hair talk, check my nails. Baby, how you feeling? Hair talk, check my nails. Baby, how you feeling? Baby, how you feeling?